So good morning, everybody. We're talking about ST elevated myocardial infarction as part of the Phenotype February 2023 effort. We have Dr. Mirza Khan and Ronald Clavillo with us here, and hopefully others will join over time. So this is to talk about the ideas on ST elevated myocardial infarction. The In terms of where ST elevation myocardial infarction stands in Phenotype February's 2023's framework is this is week 3. In other words, we start with a clinical idea. We collaboratively develop computable phenotypes or cohort definitions. We then execute that in a network of data sources, get the results, review them, and then evaluate the definitions to see if it's working. And then once we summarize them and ask an independent peer reviewer to review it. That's the framing of week 3, which is different from the week 1 and week 2. Week 1 is previously done, but an independent person has not peer reviewed. So it was developed, it was evaluated, it was posted, and somebody else, this new person, is looking at it. And week 2 is it was developed, but not evaluated and not peer reviewed. So that's week 2. And week 3 is more complex, which is it has never been developed. So you have a much more uphill task, and you also, because it's an uphill task, you have slightly more time than others. So that's the gist. So in terms of your current status, Dr. Khan, would you like to, for the recording, just state where we are and the conversation so far?
Yeah, so I know in the 2022 campaign, you all had put in a lot of work on like the acute myocardial infarction definition and the evaluation and all that's available in the posts on the forums from last year, which I've linked to in my post as well. And so Gautam and I chatted, and we talked about maybe, given my particular interest, maybe narrowing the scope a little bit to just STEMI or ST elevation myocardial infarction, as I think it'll be a little bit cleaner, but also kind of more relevant, as kind of teasing them out a little bit more. And so where we've gone so far, as Gautam kind of shared, we're going to be starting, I guess, a little bit more upstream from some of the other folks, and so just putting together some of the clinical description and how we can then, and I guess then moving forward from there is how we can kind of put those little Lego blocks together to then start to build these cohort definitions.
Perfect. Thank you for sharing that. So let's get started then. So we have 1 hour to gather, and we need to make as much progress as we can on this idea. So thank you so much for posting the clinical description for acute myocardial infarction, specifically ST elevation myocardial infarction. Is there some key ideas you would like to convey?
So I guess just looking at the landscape of what's been published, as you can kind of see in that figure, a lot of the previous published literature has emphasized or looked mostly at ICD codes, as you can kind of see, the much bigger bubbles. But as we know from phenotyping work elsewhere, the ICD codes are only kind of one sliver of the pie. And I think that there are some neat features about the acuity and the urgency with which ST elevation MI is both evaluated and treated, and the peculiarities about how it's treated as well, that we can kind of use to our advantage to maybe get even better or well-shaped phenotypes. I think that there is opportunity to do better.
And just to follow up on that, of this figure, and this is a fantastic illustration by, I guess, Rubo and others. What it shows to me, I'm just glancing, and I'm completely new to this field, is those blue circles here basically show that almost the large chunk of our studies rely on ICD codes to identify STEMI or myocardial infarction.
Oh, so I'm sorry. This review is acute myocardial infarction altogether. So this is kind of bucketing STEMI and STEMI, unstable angina, et cetera. But as you can kind of see, and there are, I think, 4 or 5 papers that they included in this review that were STEMI specific. But again, the story is the same, where there is a lot of emphasis on ICD codes for the phenotyping.
I see. And has there been ST elevated myocardial infarction specific observational studies that were based on data extracted from EHR data sources or the claims data sources?
There are a couple, and I can maybe. There are some that have looked across kind of different healthcare systems. One is it's like not Colombo, but Coloma. They have like 3 or 4 different papers that they've looked at, kind of looking at I would say kind of national healthcare system kind of things. And again, they kind of used a lot more emphasis on the ICD codes to then determine who is and who is not STEMI, which can be plus or minus. Obviously, it's not going to be 100%.
Oh, that's interesting. Oh, that's good. It sounds like it's an important problem to solve, because people are using diagnosis codes to study ST elevated myocardial infarction. Have the people who have used it reviewed the operating characteristics, done a quantitative review, bias estimate like sensitivity, specificity, positive predictive value, negative predictive value for these codes, or are they using it based on semantic lexical matching?
Yeah, that's a great question. So often they'll report kind of like the PPV in some of these standard kind of metrics, I would say. Some of them do go into a little bit more depth. One of the more recent papers being from Somani and others. Ben Glicksberg is the senior author on that paper, who's familiar to Odyssey and OMOP, and so you can imagine there that they've been a little bit I wouldn't say more rigorous, but definitely rigorous in terms of their evaluation of the model. The caveat with that particular paper, they did include, they demonstrated that, extending to include keyword searches and discharge summaries in the EKG readings. The challenge, of course, is that was just limited to that single institution of Mount Sinai. Whereas I think, again, that kind of, and it may be that their keyword searches are specific to that institution, and so it's kind of to be determined if that's going to generalize as well to others.
And did they use lab results? I know in your clinical description you stressed on the importance of troponin rise.
Yeah. I think that in theirs, they have. I don't know if I shared that one in particular, but they looked at a bunch of different ST elevation kind of criteria, and I guess what they found as the one with the highest PPV, again, kind of specific to Mount Sinai, kind of more so involved. Had a less emphasis actually on the labs and more on ICD, or if it had STEMI or a keyword related to STEMI in either discharge summary or the ECG, and didn't really emphasize the troponin in that STEMI positive or negative kind of thing.
Interesting. Okay. And in terms of in your clinical description, you had defined what STEMI is, and also kind of alluded to how it's different from just non-STEMI. I did training and worked in cardiology, I don't know, 20 years ago, I believe. And that time it was all about ST elevation was the most important thing. Is the EKG showing ST elevation along with troponin rise? But then they introduced the construct of STEMI-like idea.
Yes.
And now it's all like fully formalized into a very, very clear idea, which is essentially reversible MI. Right?
Yes.
Is what I got. Can you educate me on where the current understanding of the clinical idea is?
Yeah, there's, I don't want to get us involved
Sure.
in that scuffle, but there is now there's a faction of folks. I feel like a lot more on the emergency department side, where they actually are now framing it as occlusive myocardial infarction.
That's it.
And so, under that umbrella of OMI, you have STEMI positive and STEMI negative, and that allows them to then capture this idea of, STEMI equivalent, where you may not meet the STEMI criteria of, X number of millimeters above the baseline, but that kind of is more overarching kind of definition that also includes those instances where they have that occlusion that needs to be urgently revascularized but doesn't meet this, I would say relatively narrow definition based on the ECG criteria.
Got it. Okay. Awesome. Um, okay, so now that we have a relatively good understanding of the clinical idea, and there's lots more content here than in your post, um, we have to think in terms of a logic, right? Something that could be, we have to convert this clinical idea into something that can be converted into Atlas compatible cohort definition. And we are going to pursue a rule-based phenotyping. We're not pursuing a probabilistic phenotyping in this particular effort as of right now. So we have to end up with a JSON like this. So it's, if you and I were to brainstorm and think in terms of developing a core definition, and like Patrick said in the Phenotype February inauguration, we want to develop with the evaluation in mind. So every decision we make, we want to be able to evaluate and say, okay, what is happening? And one way of helping this is to say, I'm going to enter with a broad sweep of people who are, that is a sensitive entry criteria. Then I'm going to put some rules to remove people that don't want. That's one potential approach. If we think in terms of entry criteria, inclusion rules, and exit criteria, we could, together on this notepad, type up the logic idea.
Yeah.
What do you think of spending next 15 minutes?
Do it.
Okay. All right.
So, if I were to cast the widest net, I would start with probably, and again, so the definitions would be probably like an elevated troponin. So the widest net would probably be an elevated troponin. And so they'll say, greater than 99th percentile of the upper reference limit. And so if that is available, then we can kind of use that to make that determination. So now, there are plenty of other reasons why one may have an elevated troponin, but again, we're casting that wide net. And then I guess, yeah, the ECG data is not going to be as well structured. So that may be kind of a challenge, but if we could, assuming that it is in like the NLP table or something, or in the notes table, we could then do kind of a keyword search for, STEMI or acute myocardial infarction, like they did in that Mount Sinai paper. So that would probably be the place to start. I think the other clues to me, where again, symptoms can be challenging, that from what I've seen, but as a proxy for that, I would say if someone is shortly after they arrive to the emergency department or are seeking medical attention, if they're treated with aspirin either 162 or 325 and have like a stat, if they have the stat EKG ordered, then that tells me, hey, this person is probably presenting with, these classic chest pain like or symptoms. So that would be another clue. and then again, kind of finding another proxy would be if, again, within this relatively short time frame, if they are treated with a quote unquote loading dose of another antiplatelet medication, there's about 3 or 4 that we commonly use, then that would say to me, like, okay, this person is going to be going to get a cath pretty soon.
How about the elephant in the room, ICD diagnosis code?
Yes. Of course, yes.
You are a full clinician, Dr. Khan.
I know. You know what? That's I get to the billing after all this stuff.
Patients first, absolutely. Okay, so there is so you could enter by ICD diagnosis code, which would just imply that the person has been coded to have some ST elevation myocardial infarction. How about is there a specific procedures other than treatment?
Yeah.
Does
The
ST
PCI?
myocardial infarction PCI? Yep.
Yeah, so it would be PCI,
right?
and then plus or minus, if they got a stent. So it would be procedure code and then device.
But these procedures normally had to be before the coding, or how's the timing for the procedures normally?
So yeah, that's great. Yeah, so I think I think what's going to be helpful for STEMI as opposed to other forms of MI is going to be the timing, right? And so this, and the time information can be a little distorted, but in an ideal world, you're gonna go from, we talk about door to balloon time, so the time that they first are encountered to when they're in the cath lab and getting the balloon would be within 60 minutes of the initial presentation, or I would say 60 to 90 minutes depending on what country and wherever. And then if they are at an institution or at a hospital system that doesn't have that, then they could get treated with a fibrinolytic.
Is coronary artery bypass graft an option for certain places? Like, does that have the people?
Yeah,
I mean,
but that's going to take more time. Yeah, exactly. You got it.
Yeah, okay, awesome. Okay, so the so if we talk in Atlas framework, these could be entry event criteria that brings people combination of person IDs and dates in, right? So it is possible for a person to have an acute ST elevation myocardial infarction more than once in their lives, and we need to support that. So before we go into inclusion rules, which is the Atlas way of saying, let's add new rules to remove people that, or remove events that don't continue to meet the criteria that we want. Before we go there, let's talk about cohort exit. As you know, in Odyssey, we talk in terms of cohorts, and cohorts is defined as a structure which is subject ID, cohort start date, and cohort end date. And cohort start date is the date that the person started having the condition of interest, or estimate of the date, and then exit is when they stopped having the condition. How long does STEMI last?
I would say that hospital admission, but certainly it's going to be in their past medical history for sure. Ideally within that 2-hour time frame, from when they present to when it gets in, would be, I guess, if we want to be like the most specific, but perhaps that initial hospital admission. Yeah.
Okay, so there were 2 potential options. You could, because it is biologically not possible for somebody to continue to have STEMI for days and days and days,
Yeah, I hope not. No, otherwise, yeah, their heart will die. Yeah.
So if you could say that you could insist that the cohort end date is cohort start date. That's one option. Or you could say if they had been admitted and not discharged to home, the period of time that they were being treated was for ST elevated myocardial infarction.
Yeah.
So they
I might favor the till discharge, just because, you know, in cases where they they require like a prolonged ICU stay and those kinds of things, I would still kind of put that under the umbrella of the ST elevation MI, or complications of the actually then it would be complications of ST elevation MI. All right, let me think about that some more. That's a good point. So
yeah. And there is this is a complicated question, and I'll be the first to admit that we in Odyssey and people who do methods on how to build code, develop, how to phenotype, do not have an answer of how to best model exit. And there is methods challenge to it, but there's also clinical challenges. Most two clinicians do not agree on what the end of a disease is. Now, another question I have is, if there is a person who has an ST elevated myocardial infarction code, if a person enters the data set with these today and also enters it tomorrow, would you want that to be two distinct entry criteria for that person? So if you make cohort start date equals to cohort end date, right, same day, then all of a sudden tomorrow is an independent event.
Yeah, that's a good point.
So how would there's no answer to this. I mean, they're just
yeah.
So if entry again next date, is it a new event or independent event? An alternative approach is you can upfront say, the clinical idea you're trying to phenotype are people who are experiencing ST elevation myocardial infarction for the first time in their lives. That would be you would specifically define it upfront, saying in the clinical idea we are targeting ST elevated myocardial infarction first time in a person's life. In other words, they should not have had ST elevation myocardial infarction anytime. That by extension, persons cannot enter again.
Sure. Yeah, that's a good point.
Or you can say, if they have, you can say, I would assert based on your experience that no two ST elevation myocardial infarction can happen within 30 days of each other. And if they do, it's a continuation of the previous unresolved ST elevation myocardial infarction. So I'm just going to collapse it into something like that. And that's the framing of like the heart failure, right? If a person discharges and comes back with heart failure within 30 days, the hospital is considered, that's a quality metric.
Yeah,
that's
usually,
So that's an operational idea that you can frame to handle recurrence events.
Yeah,
that's an excellent point. And
7 days. Yeah, no, 7 days for that last argument would be too short for this. Let's say this differentiation between the two events on the 7 days. It's quite a short time, or it's possible.
No,
clinically
it's
relevant.
It's possible, right? And so, but I may actually treat that as, because people can have like instant restenosis, and so they like if that were the case, why they were presenting with all of these kinds of things, I would treat that as a separate event, because that would be a restenosis flavor of myocardial infarction, right? And so I may actually, depending on the circumstance, I may actually treat those as two different phenotypes. But again, it depends. Is this, is it another event or is it not? I think I just need to think about it a little bit more. but I could certainly see from a surveillance standpoint where we may want to, rather than just looking at the first event from a surveillance standpoint, if I wanted to say like what's the likelihood or what's the prevalence of someone having a second STEMI after the first one, then maybe treating those or disentangling those is going to be better. But then I think I would probably need to speak with some of the other clinical colleagues to make sure and see what an appropriate kind of time horizon between events would be clinically like meaningful. And I don't know the answer to that.
Yeah, and that question that you just posed is potentially a research talk question by itself.
Yeah, you're right.
So like going back to developing phenotypes with an evaluation in mind. So now we've talked about a broad entry event criteria, and all of these entry event criteria are reasonable. You could say that some of these may not be specific. So example, symptoms of chest pain with aspirin and a stat EKG may represent non-ST elevation myocardial infarction, may represent unstable angina. Hell, it could even represent gastroesophageal reflux disease.
Yeah.
Right. But I would say, I would agree with you to say chest pain loaded with a second antiplatelet. That's a much more specific compared to just getting an EKG.
Yeah.
Just by a prior expectation, without converting this into rules, we can make some assumptions of some expectations of sensitivity and specificity.
Yeah.
Okay. So let's talk about the inclusion rules. What, if present, would make the person ineligible to continue to stay in the cohort or in
I would, if the diagnosis code was, NSTEMI and then I would actually include it to be, around this encounter date, if the diagnosis code was, other causes, other things that I would typically see on like the differential diagnosis that are not STEMI.
Give me a list.
Oh,
like heart failure, you mean, kind of things?
Heart failure could be one. Pericarditis would be another one where they can actually have ST elevation on. Let me pull this up. Pericarditis.
Heart failure can be a resultant of STEMI. Is that fair?
Yeah.
So maybe if STEMI is in the pathway for it, maybe it is possible for them to coexist. We're thinking in terms of clinical ideas. If present, would just disqualify the person from having STEMI. I can think of aortic rupture.
Yeah, that would be a good one.
Sorry, these inclusion rules are zero, like not having these conditions, right? I mean, exclusion or not having these. So
manifested in the tool as exactly zero.
Exactly. Yeah. Okay. Makes I was a bit lost. Yeah. Sorry.
This is a good one. I would say Takotsubo or stress cardiomyopathy. And then in women now we're seeing a lot more cases of SCAD or spontaneous coronary artery dissection, or there's another bucket called like MINOCA, MINOCA. And then Prince-Metal angina would be another. Let's see. Oh, pulmonary embolism is going to be a good one.
Oh yeah.
And then maybe even like some perhaps like hyperkalemia and some other ones that might cause weird EKG findings. Actually, yeah, hyperkalemia could be, I don't know.
Yeah, that's a hard one, right? Hyperkalemia. Arrhythmias, you can't, you can have ventricular fibrillation because of stem.
Is it a consequence of, so it can be difficult.
You don't want to put something that is a consequence of STEMI, I would say.
Yeah.
But you may want to consider something that basically disqualifies, you can have a pulmonary embolism along with.
Yeah, that would be unlucky, but.
Yeah, that's right. These two things are usually don't co-occur. Okay, I didn't get what is that. Myocardial. Okay.
Myocardial stands for, now we're seeing it more and more. MI with non-obstructive coronary arteries. MINOCA, yeah.
Like a spasm.
So it's actually different from a spasm. But so now they're looking at kind of like the microvasculature, and say, like we can't see it on kind of the traditional viewpoints, but can we do further cardiac imaging to identify or even maybe give medications to kind of see if it's induces that kind of microvasculature to kind of do bad things. But and again, we can kind of narrow that down because that's more commonly seen among women and some of these other kind of clinical characteristics that we can kind of tease out that perhaps, or that's the other phenotype February that we can do is the Minoca diagnosis. I think that there would be a lot of interest in that for sure. Okay,
that's a good idea. So let's pursue that at one point in the future as part of the work group. So right now, so we have a framing, right? So we have a logic idea. And now this needs to be converted into an Atlas compatible JSON expression by using the tool. Do you have access to an Atlas instance?
I do not.
Okay. But you do have access to the Atlas demo site. It should be a publicly available tool.
Yeah, I think I've logged in before, but let's see. It's loading. Yep. Yeah, I'm here. And then of course the customary SNOMED accept. Yeah.
Okay. All right. So we have in terms of the progress that we made. So we clarified the clinical idea. We have come with a logic description. So one action item that you could take is to take this content and convert this into a post in the Odyssey community, it's forum post, and say we made progress and converted clinical idea into a logic idea. The next step would be to actually implement these cohorts in Atlas. And you could if you think that adding more rules or removing more rules or removing entry criteria impacts sensitivity and specificity trade-offs, you could create more than one cohort definitions for the same thing. So your action item next is to access an Atlas instance and attempt to build cohort definitions based on this logic. And I can definitely help you with that too.
Gotham, I did have a question, because I think that the timing of a lot of these interventions, getting the EKG, giving the aspirin, et cetera, are going to be can certainly help us identify these cases a little bit better. What's your sense of like the time of administration in like the medication table and some of these things? Like generally speaking, are they good, or is that kind of a pipe dream?
Depends on the data source, I think. electronic health record data sources with comprehensive data capture usually have better representation of the time of administration because PIP, barcode medication administration. Claims only data sources, not so much because the medication is the dispensation in the pharmacy.
I see.
And that means one, it's outpatient only because the inpatients are usually bundled together. And so intraday, no, not even that's a different topic. So that's an issue. So it depends on the data source. As soon as you start going into lab results, and we need to start thinking in terms of electronic health record data sources. Some claims data sources do have some lab results, like lab data that was derived because some hospital system is required to have special contract with a lab vendor by the payer, and because they have that special contract, the lab vendor would send the results of the patient to the hospital and to the insurance carrier, and so the claims data systems will have lab results, but only for those if performed at that lab vendor. So there are nuances there. And this is mostly for the US data sources. But for electronic health record data sources, some of the integrated health systems will have more comprehensive data sources with better representation of lab. Now, the second component is the OMOP CDM itself. OMOP CDM version 6 is designed to support timestamps. So you have date and time, but version 5 only has dates. So it does not have intraday granularity. So like movement within the ICU or morning and afternoon results are not captured because the CDM itself doesn't support that level of granularity.
Sure.
And right now the tools are in date granularity and not date time granularity.
Okay.
And so in terms of research questions that can be answered, we are constrained by the CDM right now, which is the date level granularity.
Okay, that's a good point. I mean, yeah, I mean that we can add that to like the limitations section for sure.
Yeah, and that was the main motivation for version 6, but it comes with technical challenges that it takes some time to resolve.
Yeah, understandable.
Yeah. So we have 20 more minutes. What would you like to do next?
So yeah, I mean, so my plan is, or what do you recommend? So I can take these kind of rules and then work within. Can I work within the Atlas demo and try to kind of put these cohort, translate these into? Can you maybe demonstrate maybe a even just a one or like a trope or something like that?
Yeah. So I'm going to go to Atlas demo, and the Atlas demo is in version 2.1.2, which is great. That's the latest version. So there is the Atlas version and the Atlas Web API version. So both are in 2.1.2. So it's the latest version. And the latest version comes with certain new enhancement, which would be very useful for you, I believe. So let's start with the new cohort, and I'm just going to show you, show ST elevated myocardial infarction. And we have, let's bring the main domains.
Oh, yeah. Okay.
Yeah, so I'm going to bring the main domains here. So there's condition, procedures, lab results, ECG, symptoms, condition, symptom. So so the way I like to do this is to think in terms of Atlas language. So there are certain things called the condition domain, and the condition domain would include ICD codes, and it could potentially include these, I believe. And that's so ECG data I believe there is a code, a diagnosis code for ST elevation. And I remember that from my last year's work. And it belongs to the condition domain. So I think you can capture ST elevation by EKG by a code, structured data. Symptoms, chest pain is, I think, an observation domain. It could also be a condition domain, but we have to check. So let's call this condition or observation domain, which are the two main tables, and remove these. So we got that captured. This is obviously the procedure domain. And this is measurement domain. So now, so we can, if the person can enter, if they satisfy the rules of a condition or observation domain, if they satisfy the rule of a procedure domain, or satisfy the rule of a measurement domain. Okay. So let's try to tackle that, and we'll try to convert this again. So now we'll start, they can enter by a condition domain, and we said they can enter by an observation domain, they can enter by a procedure domain, and they can enter by a measurement domain. The next step is to build concept sets. So we are talking about myocardial infarction, and in myocardial infarction, we can actually, let's do ST elevated myocardial infarction, and I'm just using a term, and what the innovation of 2.1.2 is this shopping cart. So when you click on the shopping cart, instead of the search button, it does a different type of search, which is unique to what Atlas. It brings you a concept set expression automatically, and it will show you the included concept. So it's already done half of the work for you. Yeah. Because you gave it just ST elevated myocardial infarction, it intelligently picked up segment and so on. You know, some of them, some minor nuances, and said, these are your stuff. What do you think? Now you can glance over it and say, looks good, you know, whatever, make a semantic based judgment. But it is also giving you things are good, but it is not sure. So it's saying, look here, there is myocardial infarction, there is acute myocardial infarction, acute ischemic heart disease, coronary occlusion, you know, things you may want to consider if you want. And there is something called ST segment elevation also.
Oh yeah, okay. Yeah.
So it starts becoming okay. The inferior segment elevation. So the counts in here seems low to me. So usually these counts represent the number of people in the data source that may have that code. This is running on fake data, so you do not have good reliable numbers. And that's going to be a problem because having those numbers will help you prioritize this sort order. And what's the point in wasting time and looking at a code that has absolutely no records, for example? So prioritizing sort order is something that you may have difficulties with, and this is where I can help you. I have another tool which is also part of Odyssey, and that is the Atlas Phenotype.odyssey.org, which has more robust counts. But keep that idea for a later conversation. But you can do the following in Atlas demo. You can now look at this recommended list and make a decision of whether you want to add something more. And this is again by your semantic understanding. There is Atlas tells you why it is recommending it, and it has 3 reasons. And the big innovation of 2.12 is something called patient context. It is saying that persons who have this particular code seems to also have these things.
Oh, so it's like a co-occurrence kind of thing.
kind of co-occurrence, yeah, concept similarity. It's a little bit more complicated than with the simplified explanation that I provided, but you get the point here.
Sure.
So when you're building it, this is one approach, and you may want to create, different combinations of it. So now that I have that, I'm going to import it from the repository. And you have to be patient with Atlas demo because it's running on a very small infrastructure, and it is used by several people. So I now have an entry event criteria called based on diagnosis code. You can look at and compare with the paper that you shared for myocardial infarction to see if the codes more or less match. So if I filter by ICD-10-CM, you can see these codes, and you can compare to the codes that was in that paper to see, okay, do I have all the codes? What am I missing? An interesting observation for me right off the bat is I do not see any ICD-9 here.
Yep.
And that was because in the ICD-9 vocabulary, which is 20 years old, there was no such thing as ST elevation myocardial infarction. So that's the point. And you could say, because the concept of ST elevated myocardial infarction is more recent, and the data capture using ICD-9 has been much older, this core definition is probably not applicable for data sources that are our patient care experiences captured more than 10 years ago. Just you could say that, and you could assert that by looking at diagnostics as part of later stage, if you want to. If you observe it. So that's so we got condition occurrence. The next rule was ECG data, right? So we saw something called ST elevation, and ST elevation. I'm assuming that ST elevation so I'm using the shopping cart again, see how it's going to behave. ST elevation represents an observation of ST elevation, presumably from EKG. I don't know if there's any other way to get ST elevation. In this particular example, the concept recommender failed. It gave me something totally wrong. And this is a recommender system, right? You as a human being has to make the decision. So I'm just going, okay, I don't like it. So I'm going to remove it. And now I'll do a simple search. And I'm going to pick ST elevation from it and its descendants. And I created, okay. Did not come there. It went to the cohort definition. So here's the ST elevation concept, and that includes certain things, but not from ICD codes and so on. So that's so now I could say, okay, now that I have ST elevation, and ST elevation belongs to the measurement domain, I'm going to add that to measurement. So so you have to continue down the list of building the cohort this way. And if you get stuck at any time, you can message me and I'll help you out, and we can make progress. And it's part of it is you have to do it yourself.
Yeah. No, I mean, there's trial and error. I mean, it's an iterative process, but it looks fun actually. Yeah.
And then there are more complex criteria. So you could say like, ST elevation, you said, okay, but just having an ST elevation may not be sufficient. You may want chest pain with ST elevation. So let's create an expression called chest pain. I should have typed the that, okay. So now, so, and I know I'm moving very fast, and that's because I'm just familiar with the tool. But the point here is we've built this chest pain. Chest pain belongs to the condition domain. So I could do a rule like this, which is kind of nested. So I could say condition occurrence of chest pain. And then inside that, I can say and a nested having a measurement that is on the same day of, so 0 days before, 0 days after, of ST elevation. So this resolves to chest pain, and on the same day, ST elevation.
That's awesome.
So
Gautam, is this in the Eden Academy, like this kind of walkthrough?
Well, if you give me permission, I'll put this video to Eden Academy.
Okay.
I mean, not me, but I'll ask Nige, who runs the tutorials.
Okay.
Is that okay?
Yeah, that'd be great. Oh, that's really awesome. I like the nesting feature.
Yeah, so in the nesting, you can try to tackle some of these ideas of chest pain with aspirin with stat EKG. And
yeah,
I don't know if
exactly.
stat EKG is represented, but you can do it. And the granularity is in days, not in minutes. You can also create concept sets for procedures for PCI. And I know people have done that before. You can do concepts for troponin. This gets a little tricky, just like in the previous conversation with Dr.
Neutropenia. Yeah.
And the neutropenia conversation.
Yeah.
So there is, you could explore chest pain and testing for troponin. That's the lower bar. You can then go testing chest pain, testing for troponin, and a troponin value above a certain threshold, just like the neutropenia example. The 99th percentile of upper reference limit. If upper reference limit, I do not know the unit of troponin. If troponin has only one unit, then life becomes easier. If troponin has multiple units, then you have to take the multiplicative factor into considerations.
Okay. Yeah. Unfortunately, from what I've seen, it's sometimes they'll do it in like nanograms per liter or like micrograms per something, which yeah. Yeah. Okay. And no, that's really helpful.
In terms of this decision, that's handled here, and you could say, you could just say here. Oh, here. No. Fixed duration related to you can say fixed duration related to the initial event, and then define that as end date. So this usually corresponds to it might change, but that's probably the best approximation of discharge date. It's not a true approximation because we are anchoring on a condition. If you anchor it on a visit, then that's the visit start date and visit end date. It will be exiting on visit end date, but that's pretty complex. I would, in terms of simplification, I would recommend you to focus on first occurrence of myocardial infarction and not worry about end date, at least for now, because you have lots of issues to think about just in the entry criteria.
Yeah. Okay. That sounds good.
Awesome.
Hey, can you send me the notepad stuff that you'd put together?
Oh yeah. So let me email this to you, and yeah, I'll do that.
Okay, awesome. Sounds good. Thank you so much, Gautam. Thank you, Ronald, for joining and giving such valuable input. Let's we'll keep in touch and keep it going on the forums. And have a happy Phenotype February.
Yeah,
Thank
let
you,
me know if
Dr.
you need
Khan.
something. I can run. We have several instances in Odyssey
Oh, that'd be great.
databases. So when the time comes, we can evaluate the core diagnostics and things like that we need to pull up there. So
cool.
yeah, or we can also work together in developing the phenotype.
Sure. Do you know what your Odyssey username is or handle? Because then I can just tag you.
Let me see. I don't remember. I need to check my email. I think it's RF. I think it's that one.
Okay.
Yeah. So we can work together developing it. I've been also working on this phenotype, so we can use what I have and enhance it or
that sounds great.
progress faster. I would say, yeah.
Yeah. Okay, cool. This was amazing.
Yeah.
Thank you both.
Sure.
And let's keep it going. Cool. All right, y'all.
Yeah.
All right.
I'll see you.
Thank you.
Thank you.
Bye.
Have a nice day. Bye.